Assalamualaikum warahmatullahi wabarakatuh. Today I will talk about the urinary incontinence in a frail elderly woman. So especially young patient, woman yang incapable to do their daily activity. So in the definition of urinary incontinence is involuntary leakage of urine. So in the elder woman, actually they is undertreated or under diagnosis because due to first they afraid about the side effect of the drug. Number two is underreporting of the symptoms. They not tell the doctor about the symptoms that they experience. Right, never seek any treatment because the embarrassment, they shy, and then lack of awareness, and then there is a mythology that this is because of aging. So the story, the telling story, but this is because of age related, right? And then low expectation from the doctor and the patient. In terms of there is a condition that contribute to urinary incontinence. First, maybe because of her high center problems, because of dementia, stroke, okay, Parkinson disease, and anxiety or depression. Number two, ada medical problem like diabetic, heart problems, okay, heart problems with the medication, and sometimes constipation also contribute of urinary incontinence also, and chronic COPD, okay, right, because frequent coughing and keep coughing, so they lead to urinary incontinence because they increase the intra-abdominal pressure at the same times. Others condition like heart, and then the urinary incontinence, they affects the quality of life. So mostly women, they anxiety, they depressed with the, and then reduce the quality of life, and then they tend to get nocturia at night times, and then and then urinary incontinence, okay, and urinary tract infection. So age wise, so I agree, age wise they affect the quality of the urinary tracts. So they affect the symptom by the age wise. Example, the bladder first, the bladder issue, the bladder function. You increase the age, so the collagen deposition at the bladder wall. So at this moment, the elasticity of the bladder wall to doing the fillings and then the voidings is reducing. The function was reducing. That's one, the bladder. Number two, the residual volumes. So in the young woman, the residual volumes indicate incomplete voidings. Mean in young women, if the residual volumes remains about more than 100 cc, so it's a sign of incomplete voidings. But in the elder woman, it can up to 200 mils. So what we afraid about the residual volume, if more than 300 cc the residual volume after voiding, okay, this one, and then they can get the acute renal failure or bilateral renal hydronephrosis because dilated. And then vagina issue changing in the young in the elder age. So first, as you know, is a hypoestrogenism state, is the elasticity also reduced. Number two is the reduce of lactobacillus, the normal microflora in the vagina, and then they change to pathogen microorganisms like E. coli and like E. coli, for example, right? In term of that, drug also can contribute to urinary incontinence. For example, alcohol, alpha beta blocker, alpha adrenergics, diuretic drug, cholinesterase, caffeine, and then opioid and sedative drug also. About the gynec cause is like a cystocele, pelvic organ prolapse, and then compression symptoms by uterine fibroid or ovarian mass or any mass. Okay. In during how we manage the patient present to you with that urinary incontinence. First, the symptom wise. So from the symptoms, you must differentiate between is overactive bladder or stress urinary incontinence, or because of functional urinary incontinence or mixed urinary incontinence. So for the overactive bladder first is a urgency with or without urge and urinary incontinence. So it's associated with the frequency and nocturia. There is a two type of overactive bladder. First is a wet or overactive bladder, which common in young. So wet overactive bladder is a urgency plus urge urinary incontinence. Overactive bladder dry. The second one is overactive dry. It's a common happen in the elder women. It's urgency without urge in urinary incontinence, be it because of neurodegenerative disorder or any cardiovascular, cerebrovascular problems. Okay, and then number two, about stress urinary incontinence, is an involuntary leakage during exertion, sneezing, coughing, because it's increase of intra-abdominal pressure, mean pressure from above the stress. Okay, and it's common happen after menopause. Okay, and then otherwise is because of incomplete bladder emptying. So this is because of under overactive bladder also actually, and then at the same time is secondary to bladder outlet obstruction. Maybe because of the neurological issue, the spinal cord lesion or multiple sclerosis, and peripheral neuropathy, for example like diabetic neuropathy, and constipation also sometimes. Okay, alright. Second, you must assess the history. You ask about the urinary symptom, bowel symptoms, and then how the fluid intakes, and then any past medical history that related with, like I said before, the cause of urinary incontinence and drug I already mentioned previously. And then social history, you ask the quality of life. So how the urinary incontinence impact her life. Alright, and then functional status, ability, is it have a caretaker, and then quality of life, ability to doing the daily activity, is a dependent or independent, life dependent or independence. In examination, you just seen the BMI, and then abdomen, any mass, right? VE, you check any pelvic organ prolapse, and neurological assessment also is important. In terms of examination, like as usual, in ONG we did the ultrasound examination to see any mass, right? So number two, other is like bladder diary is maybe helpful to quantify the amount of urinary incontinence, and also the fluid intakes and voiding time and the quantity and frequency, post-voidal residual urines, and urinary UFME, also urinary urinalysis. About the urodynamic study, actually we do the urodynamic study actually before we plan for surgery. In elder frailty, we more conservative management, so it's unnecessary to do urodynamic study. The management of urinary incontinence in elder women is lifestyle modification. So first is you must advise patient about the hygiene, the care of the perineum hygiene. Okay. Number two is fluid intake, and then reduce the caffeine intake or alcohol intake. I don't think the elder woman in Malaysia take alcohol. Reduce the weight loss and smoking. Right. And then medication, just review the medication. You can adjustment of the medication if necessary. Okay. About the environmental intervention, so actually environmental friendly for elder woman, means the toilet easy to access. Maybe you can do the toilet to elder woman easy. They can urination easy, go to toilet, good lighting, good floor, right? so maybe can have the handle, right? So must have a caretaker and a companion. Alright. Sometimes some at the moment they have a containment device. So because they urinate in the device, and then some of the women they use the catheterization, bladder catheterization. We have a vagina catheterization also. Okay. Right. There is a specific management in term of like stress urinary incontinence and urge urinary incontinence. In the stress urinary incontinence, uh, in a stress urinary incontinence, the conservative management is a pelvic floor exercise, and some say it's a vagina cones, right? This measure is a good for young woman, and is highly effective in the young woman because it required high motivation and high mental function, but in the elder woman is less effective in view of the motivation issue. Right, about the bladder training is the same goes, because our aim is we train the woman gradually increasing the interval between the voiding. So we advise patient how to do the bladder training, but it's the same. It's highly effective in the young woman because required high mental function, right? Scheduling toileting, so maybe we can the schedule to the toileting. In term of medication, the if fail the conservative management, our patient refuse for surgical intervention, we can use the serotonin noradrenaline uptake inhibitor, duloxetine, but it's a second line. Others is a estrogen therapy, and then we use a topical estrogen therapy. Okay, about the urge urinary incontinence, the pharmacotherapy first is an anticholinergic therapy. So we have a anti-muscarinic therapy, because as you know, the M2 is a cause the bladder dilatation and during feeling, and then the M3 is a bladder contraction. So in the young woman we use the oxybutynin, but in the elder woman this is contraindication, especially in the frail elderly woman, because it can acute associated with acute confusion. So elder woman safe to use a fesoteradine or soliternacin. Okay, the side effect of the anticholinergic is a dry mouth, constipation. So maybe we can prescribe her osmotic laxative. So cautious to use the anticholinergic in the elder woman, because they increase risk of the dementia and Alzheimer. So number 2 pharmacotherapy is a beta 3 adrenoreceptor mirabegron. This is a novel drug. Okay, you bear in your mind, it's a beta 3 adrenoreceptor agonist, because this one is a good choice in the elder woman because it's less side effects. Okay, and the men and woman more tolerable. The main contraindication is uncontrolled hypertension and then patient on digoxins. Number 3 is the desmopressin. Can not used in the elder woman because there is the side effect is a increase of hyponatremia. That our worries. Surgical treatment is if we suspect, surgical treatment is not highly recommended for elder woman because they increase the post-op complication. Maybe if indicated, if we can do the surgical intervention. So in patient that have a prolapse, pelvic organ prolapse, we can use the pessary or surgery if indicated, and anterior compartment repair if we suspected is a cystocele. Okay.